My name is Christopher Crane. I'm the gastrointestinal section leader in the Department of Radiation Oncology at Memorial Sloan Kettering. So typically, if patients haven't had an experience with radiation oncology before, they don't know what to expect, and they have a lot of anxiety. I think is important to understand. And what I tell patients is that they're going to feel anxious until the second day, and then the second day they realize that it wasn't what they had imagined it would be. So typically patients have a body, for anal cancer treatment, have a body mold made, and then they can be placed in either the supine or prone position. I put female patients and male patients in the supine position with legs slightly frog-legged. And the reason for that is that it enables optimal sparing of the genitalia. So the two structures, the genitalia is the most important structure to spare. So for males, the scrotum has to be carefully positioned up and away from the anal canal in that position. And in females, we place a dilator within the vagina for the planning and for the treatment. And the reason we do that is it's radio opaque and it shows up on a CT scan and clearly identifies the introitus and the vulva, which need to be spared to prevent long-term sexual dysfunction. So when we first addressed this problem when I was at MD Anderson, we first in the 2 and 3D era treated patients without any particular way of sparing the vulva because we didn't have the technology at that time. And I saw patients in follow-up and asked them about their sexual function, and when they said, they almost all said they were not sexually active, and females, and I asked them why, and they said it was pain at the introitus. So once we started using this dilator during treatment, it made a big difference. And in fact, we have published patient-reported outcomes that showed an improvement in sexual satisfaction from 35% to 75%. And I'd say, just in my own experience, it's never really a major discussion when I talk to patients and follow up about their sexual function. They're postmenopausal. They have. We also set them up with GYN sexual health, and they use estrogen creams and moisturizing, but they're sexually active, and I think the sexual activity is what keeps the fibrosis from forming. And what used to be called, and what people still call, vaginal stenosis, I think is not really stenosis, or maybe it is stenosis, but it's disuse atrophy is the way I think of it. If you can keep a patient sexually active, then they're not going to have fibrosis and stenosis of the vagina. And I think the trigger for that is protecting, or the key to that is protecting the introitus so that it's not painful at the beginning of intercourse. So that is not something everyone does, but I do think that quite a few centers use vaginal dilators as a way of targeting the tumor while protecting the external genitalia, because otherwise you don't really, everything looks the same down there on a CT scan. This is just a way of clearly identifying what needs to be spared. The other thing is that a dilator will displace the tissue a little bit and help bring the sensitive vulvar area, anterior vulvar area, away from the higher dose radiation isodose lines, which are just immediately posterior. So I think the patient experience is that for the first few weeks, not much in the way of side effects from the radiation. And again, with the chemotherapy, the first dose can be either uneventful, or patients can get diarrhea and sometimes nausea. And then towards the third to fifth weeks, patients end up getting increasing discomfort in the anal canal. And if that is happening sooner than 3 or 4 weeks, you have to think about other causes. And I tell patients from the very beginning that we discuss survivorship on day 1, because the treatment is extremely successful, and we know that the majority of patients are cured of their cancer, and that we want to leave them in the same condition that they were when they got the cancer. So I think it's very important in diseases where we do a very good job controlling the cancer to think about these survivorship issues from the very beginning. And there's no treatment for the sexual dysfunction that radiation causes. It's a permanent problem. So the only thing that we can do is prevent it from happening. Vaginal dryness happens regardless, because the nodes around the vagina have to be treated. And ovarian dysfunction happens because radiation, those structures are very sensitive to radiation. So in follow-up, the patients would ideally see a GYN physician who has an interest in sexual function and sexual health, and discussions about vaginal estrogen supplementation, suppository, and also about estrogen replacement, and moisturizing, and those kinds of things. Our patients find that very, very helpful. But I think it's important to discuss the sexual health aspects of radiation treatment so that patients have, an idea what to expect after treatment.